Welcome to This Explainer. Today, we're going to dive headfirst into a massive medical mystery to uncover the actual biological truth behind profound, unexplained exhaustion. For decades, conditions defined by severe fatigue have been totally misunderstood, right? They've often been completely mischaracterized as just being purely psychological. But today we're throwing that out and looking at the hard science. We're going to explore the cutting-edge neurobiology that explains exactly what happens when the human body's energy systems fundamentally crash.
Okay, so let's start by challenging an assumption I think we all make. We all know exactly what it feels like to be completely beat after a really long day. But everyday tiredness is fundamentally different from a pathological failure of your body's energy systems. To truly wrap our heads around chronic exhaustion conditions, we have to recognize from the jump that we aren't talking about needing a nap here. It's a systemic physical inability to generate and sustain cellular energy. So, here is our roadmap. First, beyond normal tiredness. 2. The biology of ME/CFS. 3. The brain's master regulator. 4. What attacks the brainstem. 5. Seeing the invisible inflammation. And 6. Treatments and pathways forward.
All right, kicking things off with Section 1, Beyond Normal Tiredness. Let's decode asthenia and fatigue.
The medical term we absolutely have to start with is asthenia. Now, this isn't true intrinsic muscle weakness. It's not like what you'd see in muscular dystrophy, where a muscle simply refuses to fire on the very first try. Instead, a patient dealing with asthenia might actually display totally normal peak muscle power for just a second on a doctor's exam, but they experience this distinct, overwhelming inability to sustain that effort. It's like the gas tank just violently empties and their body flat out refuses to keep going.
Because asthenia is honestly so common, doctors have to play detective and rigorously rule out 4 distinct categories to make sure they aren't looking at a mimicking condition. They check for organic asthenia, like the massive metabolic drain you get from hypothyroidism. Then there's functional asthenia, which includes that incredibly heavy molasses walking sensation you see in major depression. They also have to look for medication-induced asthenia, from everyday things like beta blockers, and psychophysical asthenia driven by chronic stress. Running this rigorous screening protocol is absolutely vital before anyone gets a chronic diagnosis.
Which brings us to Section 2, the biology of ME/CFS, or what happens during a multi-system failure.
Once all those mimicking conditions are totally excluded, we arrive at myalgic encephalomyelitis or chronic fatigue syndrome, usually just called ME/CFS. And the absolute defining clinical feature of this illness is post-exertional malaise, or PEM. Guys, this is not just feeling a bit sore after a workout. PEM is a severe, delayed worsening of symptoms following minimal, physical, cognitive, or literally even emotional exertion. A crash can plunge severe patients into a state where they are permanently bedbound, requiring 24/7 care. They even get extreme sensory hypersensitivity, where normal, everyday light or the sound of a voice actually triggers physical pain.
If you put someone through a 2-day cardiopulmonary exercise test, healthy controlled subjects are going to maintain or even slightly increase their performance on day 2 simply because their cardiovascular system naturally adapts. But ME/CFS patients, they display a clinically significant decrease in their work rate. Instead of adapting, the ME/CFS body just completely fails to produce normal cellular energy, or ATP. It's forcefully pushed into this super inefficient backup system called anaerobic glycolysis, which rapidly dumps painful lactic acid right into the muscles.
And this whole systemic failure is compounded by severe immune dysregulation. For instance, patients show a massive drop in the function of their natural killer cells. That essentially means their primary immune defense is totally disarmed. Furthermore, you get these rogue autoantibodies that start attacking the body's own receptors. That friendly fire impairs vascular autoregulation, meaning their blood vessels quite literally forget how to adjust to gravity, which drives completely debilitating conditions like postural orthostatic tachycardia syndrome, or POTS.
Let's zoom in a bit for Section 3, the brain's master regulator, the Reticular Activating System.
Right in the core of your brainstem is this highly connected network that basically acts as the brain's main switchboard. It's called the RAS, and it is the principal regulator of your arousal, your wakefulness, and your overall cortical attentiveness. It's neatly organized into 3 vital columns. The median column handles mood and sleep. The medial column coordinates your muscle tone and autonomic rhythms, like keeping your heartbeat steady. And the lateral column acts as your sensory filter. If this master switchboard glitches, the entire body's homeostasis just rapidly falls apart.
Modern neuroimaging has actually mapped this specific glitch out. During cognitive exertion, ME/CFS patients exhibit totally absent signaling between specific parts of the brainstem.
specifically the medulla and the cuneiform nucleus. When this subcortical integration fails, it disrupts the crucial communication highways deep inside the brain. Researchers literally call this brain fatigue syndrome. It causes major memory deficits, altered muscle tone, and a level of severe mental fatigue that is entirely independent of depression.
So that begs the question for Section 4. What actually attacks the brainstem? Let's look at two upstream drivers.
Because the brainstem acts as this master switchboard, we really need to know what's driving the dysfunction. Culprit number 1 is the vagus nerve infection hypothesis. Think of the vagus nerve as the main fiber optic cable between your organs and your brainstem. The hypothesis lays out a brutal cascade. First, a virus infects the sensory vagal ganglia. Second, this causes chronic activation of surrounding glial cells, which then start pumping out pro-inflammatory cytokines. And third, those cytokines relentlessly bombard the nerve, basically tricking the central nervous system into a permanent, exhausting sickness behavior state. It's a localized peripheral fire, causing a massive central meltdown.
The second major driver is purely physical, mechanical deformation. We see this a lot in hypermobile patients, like those with Ehlers-Danlos syndrome. Imagine your own skull physically compressing your brainstem. That is the terrifying reality for these folks. Lax ligaments allow the skull to shift and literally compress the tissues of the brainstem. This ventral compression, combined with kinked vertebral arteries that choke off blood flow, creates localized hypoxia. The brainstem is structurally squeezed and starved of oxygen, forcing those super delicate tissues to operate on painful anaerobic metabolism.
Moving on to Section 5, Seeing the Invisible Inflammation. This brings us to a massive 2026 imaging breakthrough. So for decades, trying to actually measure this exact type of low-grade neuroinflammation in living, breathing patients was almost impossible. Historically, researchers relied on TSPO PET scans. There was a famous 2014 study that showed widespread brainstem inflammation, but trying to replicate it sparked massive scientific controversy. Why? Well, because of severe limitations with the tracers and a basic failure to correct for the physical pulsing of the brainstem with every single heartbeat. It was like trying to take a crystal clear picture of a moving train with an old Polaroid. It just created blurring and tons of false negatives.
But then, in 2026, we got a total breakthrough. An incredibly advanced MRI model called diffusion-based neural inflammation imaging basically used mathematical magic to isolate water diffusion in the brain. It finally bypassed all those old tracer limitations. It definitively proved that ME/CFS patients suffer from significant cerebral edema, widespread cellular infiltration of those activated glial cells we talked about, and axonal swelling. And here is the kicker. The severity of this visible neural inflammation correlated perfectly with the patient's clinical disability scores. The physical, objective evidence was finally undeniable.
Finally, let's look at Section 6, Treatments and Pathways Forward. How in the world do we start rebalancing this system?
Well, a major pharmacological intervention shaking things up right now is low-dose naltrexone, or LDN. This is a total paradigm shift away from standard pain meds. By operating at microdoses, LDN acts as a non-opioid TLR4 antagonist. That means it physically blocks the inflammatory cascade and forces those activated neurotoxic microglia right back into a resting state. It also triggers this cool transient opioid blockade that tricks the body into producing its own natural endorphins, all while restoring the calcium signaling in those compromised immune cells.
And honestly, what is truly staggering here is the real-world clinical impact. 70 to 74% of ME, CFS, and fibromyalgia patients experience a significant reduction in their pain, way better alertness, and enhanced physical performance when they are treated with a carefully titrated regimen of LDN. By directly targeting the root microglial-driven neuroinflammation, it achieves results that standard membrane stabilizers or your run-of-the-mill antidepressants literally just cannot touch.
Now, for the specific subset of patients whose illness is driven by that physical, mechanical compression we discussed, the approach is obviously very different. When conservative therapies fail, a high-risk surgical intervention called occipitocervical fusion, or OCF, might be the only option. Surgeons permanently align and stabilize the skull and upper spine to eliminate that brainstem compression and restore normal blood flow. It is a massive surgery, but incredibly, well-documented case series show some previously completely bedridden patients experiencing near complete remission of their symptoms right after they get stabilized.
For the broader ME/CFS population, the rehabilitation guidelines have thankfully been completely transformed. The outdated and frankly deeply harmful graded exercise therapy that basically forced patients to push through the pain has been totally thrown out. Modern protocols now dictate strict clinical pacing based on real-time heart rate monitoring. The entire goal is to make sure patients stay securely within their individual energy envelope. You absolutely cannot exceed that broken anaerobic threshold if you want to prevent those catastrophic post-exertional crashes.
By finally recognizing ME/CFS and asthenia not as vague, subjective complaints, but as hard, undeniable biological failures of the brainstem's master switchboard, we are opening the door to genuine neuroimmune healing. We've traced the entire path, from cellular metabolic failure down to brainstem inflammation and even mechanical compression. As science gets better and better at mapping these intricate biological bottlenecks, it leaves us with a really powerful thought. What other profound medical mysteries are just sitting there, waiting for us to finally view them through the exact right objective lens?